Hello, this is Todd Olsen, and I am a surgeon practicing with the Permanente Medical Group at Kaiser Hospital in San Leandro. This presentation on fluids, electrolytes, and acid-base disorders is prepared for the UCSF medical students who are visiting our hospital for the third year medical student rotation in surgery. If you have any questions or comments, please call, text, email me, or leave a comment. Some of the material in this presentation is taken from this book. Dr. Pestana is a former chief of surgery at the University of Texas. In addition, some of the material in this presentation is provided by Dr. William Schechter. Dr. Schechter is a former chief of surgery at San Francisco General Hospital. For the presentation, I have gone through the provided syllabus in sequence. I have tried to highlight those areas that are useful for patient care and those areas that often appear on examinations. This question is one of the classical questions used with surgical residents and students in surgery. A patient with severe peptic ulcer disease develops pyloric obstruction and he has protracted vomiting of clear gastric contents without blood or bile for several days. He looks clinically dehydrated and his serum electrolytes show sodium of 134, chloride 82, potassium 2.9, and bicarbonate 34. Rehydration would best be accomplished with, and the choices are given below. By the end of this presentation, you should understand why the chloride is low, why the potassium is low, why the bicarbonate is high, why the patient has an alkalosis, and what would be the best strategy for rehydration. This is objective number 1 from the syllabus for fluids and electrolytes and acid-base disorders. List the normal range of sodium, potassium, bicarbonate, and chloride in serum and indicate how these ranges change in perspiration, gastric juice, bile, and ileostomy contents. It would be best to know the normal range of sodium, potassium, bicarbonate, and chloride. However, lab results are typically given with an indication that a value is abnormal and easy access to the normal range. For perspiration, the values do not need to be known at all, except to understand that if a person perspires excessively or loses fluid in any other way, replacing only with water and no electrolytes, the electrolytes would be abnormal. A couple key points are embedded in the table. Gastric juice has high chloride, and everything distal in the GI tract has relatively higher bicarbonate. Also, potassium is distributed throughout the GI tract, and this will be a factor a little later in the presentation in discussing the mechanisms of development of hypokalemia as well as the treatment of hyperkalemia. The next objective is to list at least 4 endogenous factors that affect renal control of sodium and water excretion. The answer is number 1, renin, number 2, angiotensin 2, 3, ADH, and number 4, aldosterone. Explanation is given in the following slide. Renin is produced in the kidney and catalyzes the conversion of angiotensin to angiotensin 1. Angiotensin 2, whose precursor is angiotensin 1. This causes arteries to constrict, resulting in an increase in blood pressure and decreases in the glomerular filtration rate, resulting in water retention. This also increases thirst. ADH, or antidiuretic hormone, is made in the hypothalamus and released by the posterior pituitary. This causes water resorption in kidneys and arterial vasoconstriction. Aldosterone, produced by the adrenal glands, causes resorption of sodium and water, which increases blood volume. Objective number 3, list at least 6 symptoms or physical findings of dehydration. These are thirst and dry mouth, tachycardia, low blood pressure with low orthostatic blood pressure, dry skin, dry mucous membrane, somnolence, dizziness or lightheadedness, low urine volume or concentrated dark yellow urine, decrease in skin turgor and or sunken eyes, change in weight, and a sunken fontanelle in the newborn. Number 4, list and describe the objective ways of measuring fluid balance. These are to measure the ins and outs, You can see from the diagram at the left that some of the ins and outs are actually insensible. The next way to measure fluid balance is to check the patient's vital signs, the skin turgor, the trend in the weight, the BUN and creatinine, and the chemistry results, including the electrolytes. Objective number 5, list the electrolyte composition of the following solutions. Normal saline is 154 milliequivalents per liter of sodium and chloride. 1/2 normal saline and 1/3 normal saline have 1/2 and 1/3 of 154. D5W has 50 grams per liter of dextrose. Ringer's lactate, for some reason abbreviated LR, has electrolyte concentration similar to the electrolyte concentration in extracellular fluid. LR also has lactate, which is a bicarbonate precursor. When giving IV fluid to a patient who may be dehydrated, typically due to recent trauma, surgery, or excessive fluid losses from the GI tract, the answer is almost always to use an isotonic fluid. These would usually be either normal saline or LR, with LR used for the acidotic patient, low bicarbonate, and normal saline for the alkalotic patient, high bicarbonate. More about alkalosis and acidosis in a bit. Objective number 6. In the following situations, indicate whether serum sodium, potassium, bicarbonate, chloride, and blood pH will remain stable, rise considerably, rise moderately, or fall considerably. And the situations are excessive gastric losses, high volume pancreatic fistula, small intestinal fistula, biliary fistula, and diarrhea. The main points are, first, gastric secretions contain hydrogen ion and chloride, and everything distal contains bicarbonate. As hydrogen and chloride are lost from the stomach, the bicarbonate rises considerably, and the chloride falls considerably, and the blood pH rises. For losses distal to the stomach, bicarbonate is lost and serum bicarbonate falls, and blood pH decreases. The second main point is that as K is contained in both the stomach and distal GI tract, both excessive gastric losses and diarrhea cause hypokalemia. Sodium is a marker more of the tonicity of the extracellular fluid and does not change reliably in fluid loss states. The sodium concentration will be discussed a few slides ahead when we discuss hyper and hyponatremia. This slide contains no new information. It is just to reinforce that for dehydration due to gastric fluid loss, hydrogen ion is lost with corresponding increase in serum bicarbonate and a metabolic alkalosis. With dehydration due to losses distal to the stomach, bicarbonate is lost with a decrease in serum bicarbonate and metabolic acidosis. Objective number 7. In the following situations, indicate whether serum and urine sodium, potassium, bicarbonate, chloride, and osmolarity will remain stable, rise considerably, rise moderately, or fall considerably. And the situations are acute tubular necrosis, dehydration, the syndrome of inappropriate ADH secretion, diabetes insipidus, and congestive heart failure. For acute tubular necrosis, the kidney loses the ability to reabsorb sodium, so urinary sodium is relatively high. For dehydration, the kidney aggressively reabsorbs sodium, so urinary sodium is relatively low, and the urine is very concentrated. For the syndrome of inappropriate ADH secretion, SIADH, ADH causes excessive water reabsorption, so urinary sodium is relatively high and serum sodium is low. This is one of the more common causes of hyponatremia. Diabetes insipidus is a large amount of dilute urine due to insufficient ADH or insufficient ADH effect. For diabetes mellitus with high glucose levels, glucose is excreted in the urine with obligate water loss. This is typically considered a separate mechanism. For diabetes and water loss, the kidney aggressively retains sodium and urine sodium is low. This can cause hypernatremia. There is a curiosity of history embedded in the terms diabetes mellitus, and diabetes insipidus. Diabetes is Latin, derived from a Greek word meaning similar to siphon, as in the patient is peeing like he or she is just having water continuously siphoned out of him or her. Mellitus is Latin for honey or sweet and refers to the taste of the urine. Insipidus, also Latin, means tasteless. Modern laboratory availability allows us to avoid having to taste the urine to sort this out. For congestive heart failure, this is a relatively fluid overloaded state caused by blood not being pumped through the heart. However, the fluid overload is before the heart, and downstream from the heart, the body is relatively dehydrated, so the kidney compensates by retaining sodium and water, creating a vicious cycle. The next slide from Dr. Schechter's collection deals with SIADH specifically. SIADH is commonly on tests given to medical students and residents in surgery. This is one of the most common causes of hyponatremia. The ADH is produced in the hypothalamus and released by the posterior pituitary. The normal function of ADH is to respond to a hypertonic and dehydrated state by causing water reabsorption in the kidney. ADH also causes arteriolar vasoconstriction. The urine is then relatively hypernatremic and hypertonic, and the serum is hyponatremic or hypotonic. The most common causes of inappropriate ADH release are CNS abnormalities due to trauma, tumors, or stroke, and peripheral ectopic ADH production from a variety of tumors, most commonly small cell lung cancer. If confronted with a hyponatremic patient with head trauma or other CNS abnormality, the cause of the hyponatremia will frequently be SIADH. The treatment is fluid restriction. Objective number 8 is to describe the possible causes, appropriate laboratory studies needed, and treatment of the following conditions: hyper and hyponatremia, hyper and hypokalemia, hyperchloremia, and hypochloremia. Hypernatremia is a relative loss of water or other hypotonic fluid. When thinking about hyper or hyponatremia, in general it is effective to just substitute tonic for natremia. Therefore, to a first approximation, the hypernatremic patient is hypertonic and the hyponatremic patient is hypotonic. The major symptom is thirst. Hypernatremia can be associated with low normal or high extracellular fluid volume. The major causes of low-volume hypernatremia are inadequate intake of water, severe watery diarrhea. The major causes of normal volume hypernatremia are excessive excretion of water from the kidneys due to diabetes insipidus, inadequate production of ADH, also called vasopressin, or impaired responsiveness of the kidneys to ADH. High-volume hypernatremia is not common. One potential cause is intake of a hypertonic fluid, such as seawater ingestion. Treatment of hypernatremia is with a hypotonic solution, D5W for rapid correction and D5 half normal saline for more gradual correction. Caution is required because rapid correction of hypernatremia can cause cerebral edema. Therefore, if the hypernatremia came on over several days, the correction pace should be over several days as well. Hyponatremia can be associated with low volume, normal volume, or high volume. Hyponatremia means that water has been retained and hypotonicity has developed. Low volume hyponatremia is associated with diarrhea, vomiting, diuretics, and sweating. The causes of normal volume hyponatremia include cases with either dilute or concentrated urine. If the urine is dilute, the cause of hyponatremia can be due to drinking too much water, adrenal insufficiency, or hypothyroidism. If the urine is concentrated, once again, a relatively common cause of hyponatremia is SIADH. High volume hyponatremia is associated with CHF, liver failure, and kidney failure. Treatment of hyponatremia depends on the underlying cause. For low volume hyponatremia, if the patient is alkali, normal saline should be used, and if the patient is acidotic, LR should be used. For normal volume hyponatremia, such as SiADH. This is treated with fluid restriction, and high volume hyponatremia is treated with a fluid restriction and a low salt diet. Raising the serum sodium concentration too rapidly may cause central pontine myelinosis. One should avoid correction that leads to a serum sodium rise of more than 12 milliequivalents per liter per day. There are a couple common mechanisms for the development of hyperkalemia. These include the kidney is not excreting potassium due to renal insufficiency or the use of aldosterone antagonists, such as spironolactone. Another mechanism common in surgery is that potassium is dumped from cells either due to crush injury, ischemia, or acidosis. I have highlighted some of the words and concepts that come up frequently in the course of conversations among students, residents, attendings, and appear with high frequency on examinations. Hyperkalemia is associated with cardiac conduction abnormalities. Classically, hyperkalemia is associated with prolonged PR interval and peak T waves, although the cardiac conduction abnormalities are not always present. However, know that hyperkalemia is associated with lethal cardiac arrhythmias. The treatment of hyperkalemia. In practice, hyperkalemia, especially if unexpected, should be verified. It is possible that if there is some hemolysis of the specimen to get an artificially high potassium level. Dextrose and insulin administered can cause the migration of potassium into cells via activation of a sodium potassium ATPase. Potassium binding and elimination via the GI tract can be obtained using sodium polystyrene sulfonate with sorbitol, commonly known as KX-late. Also, calcium administration, either calcium gluconate or calcium chloride, can be used to stabilize the myocardial membrane effects of hyperkalemia. Finally, dialysis is one of the most effective treatments for hyperkalemia. Hypokalemia can develop slowly or rapidly. Hypokalemia develops slowly when potassium is lost from the GI tract or via the use of diuretics such as furosemide or Lasix. This is one of the most common mechanisms of hypokalemia development with all patients seen in the hospital. Hypokalemia develops rapidly with correction of diabetic ketoacidosis. With the correction of the acidosis, potassium moves into cells. One uncommon mechanism of hypokalemia, but appears very commonly on examinations, is an aldosteronoma. This is usually going to be the answer if you see a young patient who has unexpected hypertension and hypokalemia. The safe rate of potassium replacement is less than or equal to 10 milliequivalents per hour. In discussing hyperchloremia and hypochloremia, with few notable exceptions, hyperchloremia and hypochloremia occur simultaneously with hypernatremic or hypertonic state and hyponatremia or hypotonic state. In the clinical practice of surgery, the chloride rate, although frequently measured, is almost never addressed specifically. While sodium is the principal cation in serum, chloride shares this role with bicarbonate. So with acid-base disturbances and corresponding changes in bicarbonate, there is an expected change in chloride. If bicarbonate goes up, chloride goes down. For the initial question of this presentation, and we will address this question in detail in a few minutes, with the condition of gastric fluid loss, chloride goes down and bicarbonate goes up. This is hypochloremic hypokalemic metabolic alkalosis. Congruently, for distal GI losses of bicarbonate-rich fluid, serum bicarbonate goes down and chloride goes up. This is hyperchloremic acidosis. Objective number 9 is to describe the concept of a third space and list those conditions that can cause fluid sequestration of this type. This slide from Dr. Schechter's collection shows the distribution of total body water. Most of the water is contained within the cells, and a relatively small fraction is contained within the blood vessels. The space in between, that contains the so-called interstitial water, is where large amounts of fluid can accumulate abnormally under non-homeostatic conditions. This is known as the third space. Third spacing refers to the process of capillary leak and extravasation of protein-rich serum into the interstitial spaces of the soft tissues, such as the skin, fat, and muscle, organs, and deep space cavities, such as the chest and abdomen or retroperitoneum. It typically occurs during the first 72 hours following major surgery and is associated with a heightened stress response. Third spacing into the soft tissue results in edema, whereas fluid that leaks from the peritoneal or pleural surfaces generates ascites or pleural effusion. Large non-anatomic cavities, such as those created from extensive subcutaneous dissection or following drainage of an infected pancreatic pseudocyst, can result in large volume third spacing into the newly created potential space. Spaces that are created during surgery, such as the hernia cavity that remains following a ventral hernia repair, in which the tissues are not approximated, can result in postoperative seroma. Reperfusion following an episode of ischemia, such as in cases of arterial occlusion, result in an intense local inflammatory response and extensive tissue edema, which can lead to compartment syndromes. Next section of the presentation deals with acid-base balance. The objectives are to list the physiological limits of normal blood vessels, list the factors that affect oxygen delivery and consumption, and indicate the mechanisms, methods of compensation, differential diagnosis, and treatment of the following acid-base disorders. And these are metabolic and respiratory acidosis and metabolic and respiratory alkalosis. These are the physiological limits of normal blood gases: pH 7.35 to 7.45, PO2 80 to 100 millimeters of mercury, PCO2 35 to 45 millimeters of mercury, and bicarbonate 22 to 26 milliequivalents per liter. And the base excess is reported from -2 to +2 millimoles per liter. This diagram shows the main factors that affect oxygen delivery. Oxygen is loaded onto hemoglobin in the lungs and offloaded in the tissues. Normal function is diagrammed in blue. A left shift of the oxyhemoglobin dissociation curve, shown in green, indicates that the hemoglobin is holding on to the oxygen with greater affinity, making the oxygen less available to the tissues. Multiple factors can influence the shifting of the oxyhemoglobin dissociation curve. Two of the most important factors are temperature and pH. Either decreased temperature or alkalosis can shift the curve to the left. Conversely, a shift of the oxyhemoglobin dissociation curve to the right can be caused by increased temperature or acidosis. When shifted to the right, hemoglobin is holding onto the oxygen with lower affinity, and the oxygen is more available to the tissues. The next objective is to indicate the mechanisms, methods of compensation, differential diagnosis, and treatment of the following acid-base disorders. Two common causes of acute metabolic acidosis are renal disease with decreased excretion of acid and severe diarrhea with loss of bicarbonate. The pH is less than 7.4 and the bicarbonate is low. The compensation is respiratory with increased ventilation with PCO2 of less than 40. Acute respiratory acidosis is an acidotic state due to high CO2. The patient is not breathing enough due to drug overdose, stroke, a nervous disorder such as ALS, trauma to the chest wall, or end-stage interstitial lung disease due to pulmonary fibrosis. The pH is less than 7.4, the PCO2 is greater than 40, and the compensation is renal with increased retention of bicarbonate. Two common mechanisms of acute metabolic alkalosis are excessive vomiting or a side effect of diuretics. These include the loop diuretics and thiazides. This is the disorder our patient from the beginning of the presentation has, excessive vomiting leading to a metabolic alkalosis. The pH is greater than 7.4, the bicarbonate is high, and the compensation is respiratory with retention of CO2. Acute respiratory alkalosis is characterized by low arterial PCO2 and an elevated arterial pH. This occurs when the lungs are stimulated to remove more carbon dioxide than is produced metabolically in the tissues. Thus, respiratory alkalosis is commonly encountered in anxiety, panic, pain, fever, and psychosis. The compensation is renal with lowering of serum bicarbonate. Now revisit the patient presented earlier in the presentation. This is a 60-year-old, 70-kilogram male who has a long-standing history of peptic ulcer disease. 2 weeks ago, he began to vomit several times a day. The vomitus often contained undigested food and was free of bile. The plain abdominal X-ray demonstrated a very distended stomach. And the questions are, what would be high on your list in the differential diagnosis? What type of acid-base disorder would you expect to find in a patient with gastric outlet obstruction? What electrolyte abnormalities would you expect to see in this patient? Describe the features of the physical examination that would fit in with the acid-base and electrolyte abnormalities. Finally, write orders for this patient to correct the abnormalities. The differential diagnosis includes chronic peptic ulcer with associated scarring and gastric outlet obstruction, and second, malignant gastric outlet obstruction. There are others on the differential diagnosis, but for the purposes of a third-year medical student rotation in general surgery, these are best left to the enthusiast for now. The associated acid-base disorder and electrolyte abnormality is a hypochloremic hypokalemic metabolic alkalosis. It would be good to memorize this phrase as it leads naturally back to the underlying knowledge of dehydration, electrolyte disturbances, and acid-base abnormalities. There is a loss of fluid and chloride from the stomach, which leads to volume contraction and low chloride. There is a loss of acid from the stomach, which leads to metabolic alkalosis. The decrease in potassium is due to two different mechanisms. The potassium is lost from the stomach, causing hypokalemia. In addition, intracellular hydrogen replaces the lost gastric hydrogen ions, causing a relative shift of potassium into cells and contributing to the hypokalemia. The included diagram shows the reciprocal relationship between hydrogen ion and potassium ion. As an aside, for an acidotic patient, hydrogen is shifted from the extracellular to the intracellular environment with a reciprocal shift of potassium to the blood vessels. This is why acidosis and hyperkalemia so frequently go together. They go together so frequently that if you come across a patient with acidosis, hyperkalemia should automatically be considered, and vice versa, acidotic and hyperkalemic. Describe the features of physical examination that would fit in with the acid-base and electrolyte abnormalities. These are the findings of physical examination associated with dehydration and are already included in the presentation. The physical exam findings for dehydration include thirst and dry mouth, tachycardia with low blood pressure, dry skin, somnolence, dizziness, or lightheadedness, low urine volume or concentrated dark urine, and decreased skin turgor or sunken eyes. Write the orders for this patient to correct the abnormalities. The baseline IV fluid requirement is 4 milliliters per kilogram for the first 10 kilograms, then 2 milliliters per kilogram for the second 10 kilograms, then 1 milliliter per kilogram for the remaining kilograms. So for the 70-kilogram patient, this would be 40 milliliters plus 20 milliliters plus 50 milliliters equals 110 milliliters per hour. For an alkalotic patient, choose normal saline with higher chloride, and for an acidotic patient, choose lactated ringers with the bicarbonate precursor lactate. Start with normal saline, 150 milliliters per hour, which is 1.5 times baseline. Also give the patient a 20 milliliter per kilogram bolus of IV fluid, which would be 1 to 2 liters of bolus IV fluid with normal saline. In the presence of severe dehydration, if the patient has not made urine, until you know the patient has relatively normal renal function, potassium should not be given. Once the patient is making urine and the BUN and creatinine seem to be consistent with at least some renal function, the potassium can be added into the IV fluid. typically 20 to 30 milliequivalents per liter, into the maintenance fluid. No potassium should be given until urine output is established. Potassium can be given faster, up to a maximum of 10 milliequivalents per hour, but there are potential complications associated with extravasation of the high potassium fluid. Back to the original question. The patient is dehydrated with hypochloremic metabolic alkalosis. The patient will be rehydrated with isotonic fluid due to dehydration using normal saline, as the patient is alkalotic, not LR. We just want to ensure patient has renal function prior to adding potassium to the rehydration. The best answer to this question is D, normal saline with added KCl. If you have hung in this long, congratulations and best wishes on your professional journey. If you have any questions, please feel free to call, text, leave a comment, or email me.